Hello, everyone. I'm FLACO board member Kelly Conroy, also Director of Value-Based Care Strategies at Pinnacle Healthcare Consulting here in sunny South Florida, unless, of course, Mother Nature throws a hurricane at us. Pinnacle Healthcare Consulting provides a broad range of strategic, operational, compliance, and value services to health systems, physician groups, and ACOs and CINs across the country. I hope you're all enjoying day one of FLACO's 2020. Special thanks to Mark McClellan from the Duke Margolis Center for Health Policy for an excellent keynote speech on the state of value-based care. Pinnacle is proud to sponsor a panel I think you'll really enjoy. We're not waiting on the world to change. It's called Good Trouble, the ONC and CMS interoperability rules. Here's what it means for your practice. It's my pleasure to introduce some of the most accomplished entrepreneurs who have led and will continue to make a difference in healthcare. Dr. Farzad Mostashari and Anish Chopra. I met Farzad as he was leading the charge for ACOs at the Brookings Institute while writing Adopting Accountable Care, an implementation guide for physician practices. If you want a playbook on how early adopters produce measurable success with ACOs, it's a must read. Then I went on a remarkable journey as employee number 7 at Aledade, which has become a leading national ACO organization. Dr. Mostashari is the CEO of Aledade, a startup he co-founded aimed at helping primary care doctors transform their practices and form accountable care organizations. Dr. Mostashari is the former national coordinator for health IT at the Department of Health and Human Services and served as a distinguished expert at the Brookings Institute Engelberg Center for Healthcare Reform. Prior to his work at the Office of the National Coordinator, he founded the New York City Primary Care Information Project, which equipped 1,500 physicians in underserved communities with electronic health records. While working at Trinity Health, I had the pleasure of meeting Anish Chopra, the former first Chief Technology Officer of the United States. His tireless mission of making all healthcare data transparent to all interested parties is admirable. Most impressive is the Cost and Quality Index that he has created for all physicians in the United States, something I have been searching for since my early days at Palm Beach ACO. Anish Chopra is the president of Care Journey, an open data membership service, building a trusted, transparent rating system for physician networks, facilities, and markets on the move to value. He served as the first United States Chief Technology Officer and authored Innovative State, How New Technology Can Transform Government. Who better to tell us about the newly released Federal Health IT Strategic Plan for 2020 to 2025 in layman terms. We will begin with Dr. Mostashari reviewing the burning need to make it work for value-based care, followed by Anish discussing current state and ways to harness the new regulations and programs to make a doctor's life better. He will focus on EHR blocking rules, application access to their EHR, ADT feeds, and the ability to tap CMS's APIs for claims history. At this time, I'm going to turn it over to Dr. Mostashari to kick things off. Again, enjoy FLACO's 2020. I think you're in for a real special treat to hear these two speak on these new rules. Thank you. Farzad.
Hello, FLACOs. Hi, Kelly. Great to be here with my brother, Anish Chopra. Anish and I, we started working together in during the Obama transition, where we were both on the Health IT group, and we had all these big dreams, big ideas about how it was all gonna end up. And one of the things that was one of the previous times I was on stage with Anish, and he's a tough guy to be on stage with, as you'll see. We were literally, the script at TEDMET called for us to finish each other's sentences. And we're not going to do that today. But I think we are, instead of going a big chunk for me and then a big chunk for Anish, we're going to splice in and out. Right, Anish?
That's right.
All right. So I'm going to talk from the perspective, very practically. As Kelly said, I run Aledade. We are in 31 states, including Florida. We're growing. We'd love to grow more in Florida. But there's a basic set of things that all of our ACOs face, right, when we start off. And I'll walk through the chronology of that and why it's important and what we use that data for. In our talk, we had said that there's a new what do we call it? Triple strand?
I'll take it.
Triple strand DNA of healthcare, and it's new payment models, it's data, and it's
Open
the
data.
patient.
Yep.
And we'll talk about that. So when we sign up a practice, right, and we have the deadline for the MSSP program and RFI1, RFI2, right? You launch that practice and you start implementation with that practice. The first thing we do, right, is we set up interfaces to their electronic health record practice management system. We're pulling out their SIU scheduling feed, their 837 pre-adjudicated claims, and their electronic health record EHR data. And right now, we spend over $1 million at Aledade doing all that mapping, getting the data out, paying the vendors for the interfaces. And we do it, and it's painful, and we now have done it with 90 different EHR and practice management systems, and no two are the same, right? And oftentimes 2 implementations of the same EHR are not the same. And it's painful every time, and we do it anyway, because that information is so critical to us being able to do accurate assessment of who do you need to reach out to first, right? Who are the patients who need your help the most? Put your arms around those patients and bring them in, do those annual wellness visits on those high priority patients. So Anish, how is the world, we're waiting on the world to change.
Yes.
It was going to be the CCDA, that was going to be the lingua franca. We've made a lot of progress, but what is coming up that gives you hope that this process is going to be better?
Yeah, so Farzad, let's peel the onion back one layer as we get into where the world's going to move. Number one, we made a policy decision, I think embedded in the Recovery Act language, to spend the money to reimburse doctors and hospitals using the technologies that existed in the world at the time, which basically meant each electronic system in the hands of a physician has a kind of a business, a kind of proprietary database that the EHR vendors had been building over years to reflect what they thought would be important to make their software valuable. And when you have hundreds of EHRs that were available when we walked in the door in 08, 09, to then 1,000+ certified systems, that's a lot of proprietary databases that we introduced to the healthcare delivery system at a time when the dream was that we would be standardizing these databases so that they could be more interoperable. The challenge when we built the sort of let the private market be the back end of these systems and to reward them through these reimbursements for adoption is that we then had to race to get effectively a common data set that was how blood pressure would be recorded in my EHR relative to your EHR relative to Kelly's EHR. So 2 things happened that we're building upon right now. Thing number one, we do have a bottom-up list of maybe a dozen or so data elements that are not all the items you want, which is why this doesn't feel like a perfect solution, but it's progress. The industry has agreed that when I ask for a medications list digitally, it's going to look like a medications list, the same, whether I'm asking an Epic, a Cerner, an Athena, or ECW practice. That was the end of the Obama era regulations that said you've got to make that computer accessible, application accessible, right?
And I mean, one of the things we don't talk about enough, I think, is just the vocabulary part of it, right? Like when we started 2009, there were like 5 different ways of representing hydrochlorothiazide, 5 different numbering systems, and now that part is done. Like if I can get a list of medications with their codes behind it, we're all speaking the same language at least.
That's right. And so for the physicians listening on this session, the manifestation of this is that today, your patients are capable of connecting Apple Health or an Android version or any one of a number of private companies where the apps, they don't pay the $1 million mapping interfaces that you described, Farzad. They're coming in through this regulated front door where if they've been granted permission to ask and the consumer agrees to do that, then whether that app is connected to an ECW, Cerner, Epic, or whatever on the back end, the app gets what it asks for and can use it to build visualizations, trends, maybe even alerts or decision support. And that's been slowly implementing over the last, let's call it 2 to 3 years, okay? So we've got a subset of the medical record standardized that enables consumer apps to access. I say all of that long-winded history because what's new as of November 3rd, ironically, Election Day, no coincidence here, that the Office of the National Coordinator formalized regulations that apply to EHR vendors and, of course, providers themselves who are subject to certain obligations like sharing clinical notes with patients. These obligations on EHR vendors offer an incredibly new and powerful option that in addition to the consumer being able to designate an app that can ask for that information, the doctor can designate an app to ask for that same information on their entire panel. Now that's in the regulation. We've got, and we'll talk about this as we go back and forth, there's a little bit of a, you have to ask or you're not going to get capability here. So you almost have to know the magic words. The term of art here is smart on fire. SMART stands for substitutable medical applications. So if I want to download the Alidate app that's going to make my life better as I move to value-based care, I need to ask my EHR vendor for the application rights to connect your app, not to the interfaces that we've had to do for years that simply present the proprietary databases in its native format, but into this regulated plug where you're installing your plug into the socket.
So what you're seeing is a world in which soon, and we'll get back to like how soon is soon, and when is this going to be broadly available, where we at Alidate or other population health enablers would create very specific applications that conform to these smart on fire standards, which we funded like 10 years ago, right? And now they're coming into utility. But you have to rebuild basically your population health tool to be using these inputs and outputs. But then the promise is that any one of our customers, clients, partners in the practices could go to their EHR vendor, whether it's eClinicalWorks or Allscripts or Athena, and say, "Hey, put this app on my EHR." That's the
right.
dream.
And failure to honor this request could put the EHR vendor at risk of $1 million fine per instance of information blocking reported. Now we'll get into the detail as to when and how.
When does
I'm
that
happy to do that now.
Yeah, when does that start, Anish?
Okay, so this is a little bit of the gray area where I'm going to make a statement that's Anish's opinion, and it won't reflect like bedrock law. I believe in the principle of it acts like a duck, it quacks like a duck, it's a duck. So this smart on fire technical standard hasn't even been officially certified yet as a piece of software. That will happen in the next 6 months or so, and vendors have until December of 2022 to deliver that specific piece of software called the Smart on Fire Authorization Server. And I'm so sorry, physicians, that you're listening to this jargon because it's awful, and I'm apologetic on the front end. that you have to sort of track this in foreign language. But what this means is your EHR vendor has at worst until December of 2022 to certify their products that has this feature that you can install the Farzad app or anyone else's app into your EHR to help you live a better life. But in my language, in my interpretation, if the EHR vendor's product already supports Smart on Fire, which all of Epic, all of Cerner, all of Athena, most of ECW, as I understand it, if they've already shipped that technology, they can't hoard it from you until some future date. That's my opinion. So what you want to know is whether or not your EHR vendor supports Smart on Fire. The term is launch EHR. I want to launch an app in my EHR. And you want to understand how will they present the Alidate app, the Pinnacle app, the Walmart app in your EHR, and it has two features. Feature number one, it knows the patient's chart you're in. It can read the chart and present information to you in context for that patient's chart.
Yep.
Or two, it can interact with a list such that you click the list, it goes back into the chart and brings the relevant information. So you can either search within the app or you can pull it up in context. The key is asking for that Smart on Fire capability, which should be delivered across the majority of 2015 certified EHRs that are in market today.
All right, so Anish says this will happen. We just need to build the apps. They will come no later than December 22, maybe sooner. Maybe it's already here. We will wait to see who the first population health app, ACO app is, who cracks this barrier. Anish, you let us know. All right. The next thing we do is we take their list of patients who we are having under contract, and we hand it over to, in most cases, we have agreements with the Health Information Exchange. And I think, Kelly, we were the first to get Florida standing up and getting all those, and after the law change, and getting the notifications served to our practices every time there's a ER visit, every time there's, I think in Florida last month during COVID, we had over 95% of all ER visits got a phone call from the primary care practice from our practice.
Florida?
From our ACO in Florida. 95% of the ER visits had a follow-up call from the practice. That is a huge part of why we're able to get the reductions in ER visits on the follow-on calls. So it's a critical element of transitional care management, post-ER. It's part of our core 4 in that Brookings toolkit, right? But you got to be able to get the notification from the hospital when this happens. And as we know, many hospitals are kind of hoarding that information. So, Anish, how is regulations going to solve this problem for me?
So in early 2021, CMS has formalized a rule with, in full disclosure, your lobbying support, my lobbying support, and our friends, to suggest that
guilty as charged. We pushed hard for this.
At a minimum, the patient has the right to designate a primary care doctor to get the notification. So there's sort of a consumer channel for access. But for everybody on this webinar, physicians have the right to submit lists of their patients to hospitals. Now, what the hospitals must do is deliver the ADT feeds to the physicians who request it. How will be a clear area of debate. For many of you, your IT may not connect to the state HIE, and so you either have to figure out a way to connect to it, or you might consider asking the hospitals for alternative methods to transmit that information to you, maybe even via a Fire app you can install in your EHR. In the state of Maryland, the HIE has built a Smart on Fire app, And in Maryland, you can install that HIE app right in workflow, so you don't have to log into a separate system to get the ADT feeds. It shows up in context. But you can also use third-party apps that may make this more delightful for you, because it's sort of annoying having to pull the patient roster and submit it and get the feedback and make it all work in workflow. So the key piece, and I want you to react to this because we'll see how the response from the industry will play out, but there's some key provisions in this rule that put the weight of the power in the hands of the physician. If the hospital tells you that the only way you can get this ADT feed is by joining some proprietary thing that they've stood up that's irritating, burdensome, costly, they are not deemed in compliance unless they've made any appropriate accommodations, because it's almost like in the Medicare Advantage world, there's this concept of network adequacy. How adequate is the network? In this ADT feed world, I'm thinking of it as an ADT network adequacy. Are there enough doctors who want the feed on the network? And if not, the hospital will not be seen as compliant. So to me,
the simplest way, so we spent $674 million or something on funding these state HIEs.
Yep.
Right. And the simplest way for the hospital to become compliant with this condition of participation in Medicare,
That's
which
right.
is like the nuclear option, right, is to just turn your data hose to the HIE and let them distribute the ADTs.
Sure, that's the most obvious choice. That is the most obvious choice.
Yeah. So I still worry that there's going to be hospitals trying to, even though they fought this action, they fought it on the regulatory side. There was proposed rulemaking. We had comment. There was a final rule, that they're still going to resist this. And I see zero credibility or legitimacy to that, where patients' lives are at stake and they're holding on to this for some financial, like wanting to keep docs in their clinically, in their sin, right?
Yeah.
That's inappropriate. Medicare has said it's inappropriate, and I think hospitals would do it at their peril.
And the key question here is, in a world of gray, what constitutes compliance, what doesn't? Tie goes to the organization that gathers physicians' interests, almost like a labor union. That may not be the right analogy here, but if we could aggregate physician demand for these ADT feeds and present back to the, Florida's unique because it's got the statewide HIE and it works. There are not a lot of states that have them. And so either we prop up a new HIE or we come up with some mechanism to construct an HIE-like utility service that we can all tap into. But in my view, the HIE should be mostly the infrastructure, just so that the data flows. We still need to solve the workflow problem of I don't know anybody, Kelly, on this webinar who wants to log into two screens. So if I have to log into a second screen to find out, maybe the care managers do if I'm well staffed, or I've got Alidate, or I've got some resources that can kind of grab be the catcher's mitt for all these feeds. But for the primary care practices who are more independent and without a lot of support, you really want this to be in your EHR, which is why I talked about the idea of Fire apps. This could be the first app you request be working if there is such a thing. And I can tell you, Epic supports Fire apps today that can tap into these ADT feeds.
So what Anish is saying is that there's an interaction between the first thing we talked about of having an app on the EHR, and the second thing we talked about was just the data liquidity coming out of the hospitals and ERs. All right, moving along. So we've got the practice set up. They have the Alidate app going. They have their list of patients to call for wellness visits. They have their list of patients to call for transitional care management. And then the patient shows up, right? You did your outreach to them. The patient shows up, and you want to make sure you do all the right things for the patient when they show up. And a lot of times you might say, oh, but my EHR already has what I know about the patient. But what your EHR does not have is all the information in the payer claims that says they got their mammogram somewhere else, they didn't fill their prescription, they're seeing 12 different specialists. That, right, all of that information, which we present at the point of care, we call huddle print or huddle view, right? That sheet is fed by claims data. And right now, we have to wait until February, March of the following year. You're already a quarter into your performance period before you get that data integrated into the Pop Health tool. How are you going to solve that problem, Anish?
So the great news is our friends at CMS are once again building regulations and operations to help physicians get the information they need in a timely manner. So let's peel this onion back. Let's talk about regulations first. Many of you on this webinar do have relationships with payers where you're taking risk, and you might have 8 or 9, maybe 10 different payers, some of whom share data, and when they do, it's in a disparate format. So you're sort of awash in totally unstandardized claims data, and you may have to. It's a cost structure to Aledade. It's vendors charge a lot of money to deal with this. There's no benefit to any human being other than people that manipulate data from format A to B to run a calculation, which is ridiculous. So the good news is by July 1 of next year, every health plan will have at least a standardized format for patient claims updated daily for government-sponsored plans, MA, healthcare.gov, Medicaid managed care. So back to my analogy earlier with Apple Health and Android, there'll be a common pipe, not the flat files that you get shipped by your IT department, but a pipe that you can plug into with an app and you can extract data. Now, that's regulation, and it's consumer facing. So the painful thing about this is you'd have to have the consumer authorize this app in order to pull in their history. And that's culturally complicated, asking consumers for their signature to share the data or to go through any friction. So I understand the sensitivity, but that's what's regulated. CMS, though, is giving us a window into the future. They are operating in a more physician-friendly manner. As we speak, and our friends at Palm Beach ACO are one of the first to adopt, CMS has launched a program called Data at the Point of Care. So Farzad, that CMS patient that's coming in Tuesday, on Monday, you can request that all of their claims history, 4 years of their claims history, and updates that are updating, right now it's weekly, be transmitted to you. So when you do your huddle report, you've got data as recent as last week paid claims available to you through the CMS service. Now, not to go back to beat a dead horse, the condition of joining this model is that the claims data must be presented as a Smart on Fire app. Back to this demand signal, you can't just ask for it. You've got to demonstrate that you're going to use this at the point of care or this daily huddle report, and it's got to be integrated with the EHR, not a separate login. So this is all reinforcing the same themes. The regulations do require the EHR vendors to turn on these apps, and now we're getting use cases to sort of bring the data into the EHRs. And I think this one in particular has a lot of potential. So that's right. Last point, I'll let you get this one. We hope and expect all the other payers will be building that same functionality so that we'll have a consistent feed so that we reduce that $1 million mapping interfaces headache and bring that down to a reasonable number and put more emphasis on people, process, bringing them in, follow up, and all the rest.
Now, Anish, what if I have a different population health software that's not Smart on Fire in the EHR, but I've gotten ENAC certification or high trust certification that meets the CMS requirement for that?
So as of right now, the CMS team wants you to physically demonstrate that the app works in the EHR. That is the operational decision they've made for data at the point of care. And we'll defer to our friends at Palm Beach and others who are early adopters of this program to share their experience. However, I understand the point that maybe there is a mechanism to tap this feed if the EHR vendors don't make it easy to participate in this Smart on Fire piece, or you can't make it work. And so I do think it's a judgment call inside the CMS system on what they will do. As of now, in the alpha early adopter program, they want to show screenshots that the thing works in the EHR. What they don't want to do, as you could imagine, Farzad, is they don't want to have all of this sensitive health information flowing to some manager's office who's trying to run leakage reports, as opposed to really delivering improvement for care at the point of care.
All right. So we talked about the EHR, the data out of that. We talked about ADT, HIE. We talked about the payer claims data. What are we missing? Well, what about this other big ecosystem, right? Like we're getting data from LabCorp and Quest, and like there's specialist offices. Like there's this whole ecosystem out there. How is all this information going to be brought together, and what do you see as a potential role for the patient? You know,
yeah. So
one other thing, and you know, you've talked about the painful process of signing up patients one by one. I don't know if any of the folks here are going to be part of the direct contracting model,
yes,
where you kind of have to go do that painful thing if you want to do voluntary alignment. So connect the dots for me there.
Yeah. So this is where business model intersects with technology capability. And let's go through a few layers of the cake. So voluntary alignment, direct contracting is a message that you teed up that I think is critical here. The opportunity to reach underserved seniors who don't have an attributable qualifying PCP visit, but have chronic conditions and maybe rely on the ER, or have been previously coordinated and documented for having these issues, but just have been fallen through the cracks. We have an opportunity with direct contracting to have an economic model that rewards proactive outreach, especially to the high needs population who would benefit greatly from enrollment in these models. And it's almost digital malpractice to ask someone for their voluntary alignment signature and not at the same time ask for their permission to access the claims history. You'd want that to be a similar experience. Today, Farzad, 60 approved CMS apps, there are 60. Over a third of them are for Medicare Advantage shopping portals. So every one of those app developers that are building shopping portal blue button experiences are now contemplating how they can extend the work that they've done with Medicare Advantage into the direct contracting voluntary alignment. I'll make another point on business model. Ascension Centene, I think, went live in Florida in one of their 4 markets where they did this. They gave both brokers, insurance brokers, a $30 bonus if that broker could successfully onboard a patient into the Blue Button service. So there's actually an economic incentive in the MA shopping experience to do this. So that's point number 1, voluntary alignment and Blue Button, one consumer at a time. The bigger point though, and I think if you were to say, you know, where's the weight of the authority here, CMS did something pretty aggressive with respect to government-sponsored plans. Not only are those government-sponsored plans responsible for taking their claims history and converting that into an API or feeding consumer apps, but any clinical data they collect through legacy interfaces, PDFs, scanned images, all the lab feeds the payers have been paying for, everyone in the supply chain who feeds plans clinical data. The plan is now responsible for converting all of that into the equivalent of the Epic Cerner Fire API clinical feed. In my view, it would be digital malpractice for any plan not to demand their suppliers deliver that data to them in the FHIR format. Once there's a demand signal to convert these legacy long tail of healthcare information sources into the FHIR format because customers are demanding it, in this case, the plans, then I believe the marginal cost to extend that to doctor access and consumer access should be virtually nothing. So there is going to be, in my view, a payer demand signal to get the random data sets standardized. And we're going to be in this interesting dynamic. I'm encouraging every member in the Flacos community, hug a plan you love and be their alpha partner to put all this digital infrastructure together for consumer apps, physician-facing apps like the ADT feeds, and then you've earned the right to do some payer-specific gaps in care, and they're enrolled in this disease management, such and such. And hugging a plan who's investing, the industry is putting $1 billion to comply with these rules by next July. It would be a shame if the physician practices at Flacos don't extend their hand to say, make my life better, please. I'll give you application access to my EHR, but you got to help me with X, Y, and Z. Bring them into the fold because they're exerting a great deal of leverage in the industry. That's my opinion.
Well, that's a high bar of trust there.
For the one, pick the one.
Yeah. All right, Kelly, what do we miss?
There we go. Had trouble. I'm on the phone with the Chief Technology Officer in the ONC and I can't unmute myself. So you guys did a wonderful job trying to explain it to us in layman's terms, because I know this is extremely complicated. But if there's two situations I'm thinking about. If you're a physician practice and you're sitting there, you have an ACO, they are receiving these feeds, they're doing what I like to call the work around the doctor, right? They're calling the patients and the doctor's not able to do it and it's not in their workflow. So if you're sitting there today and you're hearing all the stuff, they're on the conference today and they hear everything you said, what should they do? Like, should they start a committee? Should they get some data governance? Should they, what should they do? Where do they start?
Well, always start with Farzad. Tell them the clinical goals. I would start with the problem you're trying to solve, and then we'll come back around the tools that help you get there.
Yeah, exactly right. And I think we really, and this is why I try to work backwards from what is it, the why of why you're doing it, and prioritize and focus. So, the data feeds the workflow. If you don't have the workflow, then the data is just going to sit there. And I think that's the case with a lot of health plan population health tools, and sadly, a lot of ACO population health tools. There's data in there, but there's no workflow associated with it. They're not really task management tools. So I think the first question to ask, if I'm a practice, a doc who's part of an ACO, is, do I actually have workflows around this? So if I get the HIE data, do I have a workflow to call patients after the ER visit or after the discharge? And does the tool that I have, regardless of the data feeding it part, does the tool that I have support my staff doing it in an efficient way? If it doesn't, look for a different tool and a different partner, and focus on the front end of that. My EHR, am I just putting data in there and it's never coming back out? Or is this data actually feeding the care gaps and the risk coding opportunities? Is that, how much is that being used? If I documented the patient's BMI is 43 already, do I have to then plug it in again in the quality measurement tool or in the Z-score to get the credit for it? Those are the kinds of questions that I think we should be asking from a more fundamental point of view. And once you have tools that have workflows that help you meet the population health mandates, then I think the questions are, is that group set up to keep on the cutting edge of what's possible on the data supply side? Yesterday, the cutting edge of this was a direct interface to the EHR and an HIE feed. Tomorrow, or December 22nd or 22, it might be a Smart on FHIR app. So I think that's the advice I would give to the practices.
Yeah, and I, not to fight the power as a message here, but to the extent that there's a coalition that identified the same workflow gaps and maybe even the same sources that are, maybe making it complicated. There is an information gap, Kelly, in that if you don't know to ask these questions, if you don't know to ask, can I install a third-party app in my EHR without it being another custom interface fee, then we find the problem here is, I know what I want done, I know that it needs to get done, but I think it's gonna cost me an arm and a leg, so I'm not gonna do it. And that's the worst answer. And if we could, if Flacco's can be an aggregator of this demand signal, Kelly, with your, just personality, everyone loves you. If you could be an, aggregator of this information, it'd be fun to get the early adopters who need the information to support workflows to make care better for patients. The sooner we get that demand signal, the faster we're going to get that closed loop. There's 3 legs: doctor, data supplier, regulator. And we need to activate all 3 arms to make people's lives better. And people like Farzad, myself, we're here to volunteer to help. We want to make this work. The country needs us to be successful. We can't wait for value-based care to have an impact. We got to scale the wins we have, and we got to reach more people with the models that work. And so we got to hurry. And I'm eager to support. Worst case, someone raises their hand and we fail to support them when they could otherwise deliver better care. Man, that's a lose. So we gotta get that demand signal aggregated.
So let me ask you this question. In an ACO, promoting interoperability, you had to have a meaningful use 3, I know we don't call it that anymore, a CERT EHR, right? Wasn't one of the requirements to have a CERT EHR to have a FHIR server? Like, could it be possible that a lot of ACOs that represent a lot of practices actually have this and they don't even know they have it?
Well, that was my point about the gray area. If they have a 2015 edition certified EHR, the vendor had the choice whether to deliver that in a standards-based way, smart on FHIR, or some random option that they just threw out there to get compliance. Most of the major vendors chose voluntarily to use the smart on FHIR standard, which means, Kelly, all of those doctors who had to demonstrate certification for participation in, say, for example, direct contracting, they may not know that they have the capability now, not December 22. You got to ask your EHR vendor, do you have the smart on FHIR protocol or service, and can I use it with a third-party app? And anybody on this line, connect with me or Kelly or Farzad or whomever, let me know. I would love to throw some muscle at this gap to make sure that you get the support you need. And all we need is a few examples and case studies, and I think the whole thing works. And that's my Pollyannish, positive, think the world's a better place kind of voice, but I'm confident.
We got to change the world. So did you say something about the payers are going to be the first that are mandated to do this?
Right, so December 22 is for EHR vendors and providers on the information blocking rule for the more modern sort of smart on FHIR and the whole stack. Payers, ironically, have to do that modern smart on FHIR work July of 2021, which is why I said, I hear you, Farzad, obviously there's a historical lack of trust. If we can find one that wants to do more of a collaborative model, and there are a number of payers who share this, Humana is one, Devoted is one, there are many in the Florida market who would love to be more collaborative. This may be a chance to get their motivation and investment plan aimed at helping you make your practice more efficient.
And a lot of ACOs have some sort of partnership with Medicare Advantage plans. That would be the perfect place to start because everybody wants to win.
Do you have any friends in the MA world, Farzad? They're becoming friendly.
Well, they want it to work, right? Everybody wants it to work.
And just before we close, I think there's one other technology issue that a lot of ACO and value-based practitioners have been working on during COVID, which is telehealth. And there's obviously those, as in-person visits have gone back up, telehealth visits have declined, unfortunately. We're working quite hard to keep it as part of the toolkit for delivering primary care, but there are questions and concerns around what happens in terms of the regulatory landscape and the payment landscape for having those continue. Anish, I'd love to hear your take on it, and then I have a prognostication.
Well, frame the risk you have there, just so I get the trend.
So there were payment parity on the part of CMS for telehealth visits, counting.
Oh, right. Yeah, forgive me. I take for granted that we're going to continue to see this. So you're right. This could go poof overnight. So forgive me. Look, I think two things are going to happen. One, I think first of all, the core annoying, I have to buy some specialized technology to do a video call. I think we're way past that will work. People are now able to go from having an unregulated capability to something that'll fit their workflows. So there's a beautiful way to sort of embed the sort of add the telemedicine channel into the workflow. I do think the jury is out on whether the investment did result in forestalling disease progression, or to close care gaps, or to really move the needle on preventive services versus worried well. We are actively studying this, as you know, Farzad. We have the research license at CMS, so we're going to be publishing continuously, what the actual experience is, and the patients who've had these services, what their longitudinal outcomes will look like. So I am hopeful we'll have a tweaking as needed on where it works. The most disruptive is the crossing state lines. So telemedicine companies that can offer specialty care consults in your backyard could be a blessing or a challenge. And depending on the current environment, if you're not really capable of referring someone out to a great specialist, maybe the easiest thing is to refer them to telemedicine. So I think we got a few watchful waiting here on what this will look like.
My prognostication is that there will be concern, I think, on the part of those who are actually delivering the true primary care to these patients, of having an easy push a button on the health plan app to have a telehealth visit from someone in Indianapolis or whatever, and stealing, in a way, attribution away from the ACOs. I think that is a concern that folks should have, and there are, you can make regulations to address that. But I think the bigger picture is there's a lot of optimism that telehealth waivers and so forth are going to continue for everybody, but I think their cost of those is going to be significant. And I think the overuse and fraud, when things go back to normal, is going to be a factor that's going to make payers, including CMS, preference those practices who are in ACOs or taking total cost of care in those waivers. In other words, they may,
and that's already the default
waivers. If and again, if you're moving towards primary care cap or total cost of care downside risk, then the payer isn't worried that you're going to overuse telehealth and have it be hard to audit and so forth. So I think one more reason we should be in value-based care in the years to come.
So why don't we scare everybody before we leave? So let's imagine Amazon builds a nationwide primary care, digital first, direct contracting, voluntary alignment strategy, and they go poach every single patient in every primary care doctor's practice. That won't happen, but you could envision some of these crazy, you could really put all these regulations and options on the table to really present a bold vision. So we got to be mindful of all the areas in which disruption may come in.
There's a great quote, which is, every doctor that can be replaced by a computer should be.
Yeah. Right, because that universe
cannot be replaced by computers, because what keeps primary care special is the relationships we have.
I agree.
All right, well, that's a really good note. On behalf of Flacos, I want to thank you guys. You always volunteer to come and help us and understand these rules, and we just want to thank you for always making time to educate the people in Florida. Thank you so much.
You're awesome. We love you very much. Thank you for having us.
Bye, guys.